Oh, hello, everybody. I think I've already greeted everybody pretty well. But today we are absolutely delighted to highlight the collaborative work of dedicated students and faculty and mentors. They're going to be presenting the culmination of a lot of hard work they did this semester and all the interprofessional collegial learning they did together. I'm also excited to say that we will be announcing the 2023-24 PEGNUCO Interprofessional Service Award, which will be coming up in a few minutes. As part of the direction, feel free to move between the breakout rooms and the tracks during this event. It's pretty easy there are 4 tracks and it's pretty easy to navigate through them. And also we'll be putting up an attendance form that will be we would like you to complete so we know who's the 103 people who are here. We know you were here today. The link will be shared at the very end of the presentations. And so it's my pleasure to introduce Dr. Karen Housknecht. She could not be here today, but she put her remarks on video. And so I will pass it on to Dr. Housknecht.
Hello, everyone. My name is Karen Housknecht, and I'm the Associate Provost for Research and Scholarship at UNE. I'm pleased to welcome you to today's Interprofessional Student Showcase. Our event today highlights the collaborative work of 64 students representing 17 programs across the university. Interprofessional projects such as these deepen our students' learning and help to inform clinical practice. Also, as scholarship is a foundational component of the UNE educational experience, interprofessional research and scholarship projects also lead to the creation of new knowledge and best practice with the ultimate goals of improving patient care and patient outcomes. I want to take this moment to congratulate our student scholars and their faculty and professional staff advisors and mentors. We are so very proud of the work that you do. And I also want to wish all of you a wonderful conference experience today. Thank you.
Thanks to Karen for those remarks. And now we'd like to feature Ethan Kennedy, a graduating College of Osteopathic Medical student who has been an IP champion from the beginning. He's been the student rep to the BOT at UNE and has served on several of our committees. And he's always a touchstone for us. If we are not sure how we're doing is going over with students, we always like to check in with Ethan. And he's like, you can't do whatever it is you're doing too much. And we appreciate that support from him. And so we're going to hear some remarks from him now as well.
Hello, everyone. My name is Ethan Kennedy, for those of you who do not know me, and I'm a 4th-year student here in the College of Osteopathic Medicine. Over the last 4 years, I've had the unique honor and privilege to serve on many college and university-wide committees centered around interprofessional education and interprofessional education curriculum development between the comm students and all the other healthcare professional students. It's really been an amazing opportunity over the last 4 years to provide the student voice and to work with amazing members of our administration, faculty, deans, to come up with curricular experiences for our students to enrich their not only interprofessional education, but their overall academic education. I think interprofessional education is such an important part of who we are as healthcare professional students, because of the day we graduate and we're finally out in the workforce, we all understand that regardless of our education and degree and our particular skill set that we bring to the team, we will all be serving on that team to provide the very best care possible to our patients. And I think that having that early fundamental understanding of what the other members of the team do really provide a more enriching experience. One might ask the question why I was interested in interprofessional education early on in my medical school education. And I think there's 2 points in my life that really got that ball rolling. First of all, going to an animal science undergrad and thought I was going to go to vet school for a while, understanding that there are people out there in the world who get a very similar education as a veterinarian, but they don't have human patients, and having friends who have gone to vet school and having those discussions about what you do for a sick dog, a sick cow, a sick horse really provided a different understanding of the same fundamental knowledge base, which was really impressive to me. I think secondly, serving as an emergency room technician before medical school and seeing what it was like to be a bedside aide and doing the day-to-day patient care, boots on the ground, instead of the role of the physician, was really something that I wanted to incorporate into not only my education, but understanding what it's like to serve in that role. And I think that those are the things that are really important for us as students to learn and respect about our other colleagues. I think serving on many different committees and having the opportunity to put curriculum together and long-term strategic planning together to allow for students of the future generations to have a better education has been something that's really meaningful to me and something that I've taken a lot of pride in, coming from a family of educators myself. Lastly, in this short video, I really want to emphasize the importance and the opportunity that the University of New England has in the coming years as CAIEP moves to Portland. I understand that there's going to be a lot of growing pains from a social standpoint, from a power dynamics of the campus, and I think that's something that we can't shy away from because it's going to happen. But I really want to challenge the administration and the leadership to embrace that opportunity. And even though it's going to be challenging, understand that on the end of outcome is going to be a so much better and enriching environment for academic achievement for our students. Whether it's having the opportunity to do sims together or guest lectures together or interacting between clubs and organizations, I think there's so much positive that can come from this move. And not only from a social standpoint, but from an interprofessional education standpoint, I hope that our committees and all these great people that I have worked with over the last 4 years are bold and strong and stand their ground to give these opportunities that are so critical and so important to our students moving forward for the next generation. With my last few seconds, I want to say thank you to everyone who I've had the opportunity to serve with. I hope that my input and my personal experiences as a student over the last 4 years has been helpful and enriching to our discussions and to our long-term planning. And I really want to say from the bottom of my heart, thank you for giving me this opportunity and letting me sit with you in those conversations. And, you know, it's been a lot to me. So thank you. And I hope to see everyone at graduation.
Thanks, Ethan. You have been an inspiration to us as well. So Godspeed. And I'd like to hand it over to Shelley now for a special award.
Well, first, wow, Ethan, you hit it out of the ballpark. So thank you so much. So it's my pleasure now to present. Every year we present the Pagnuco Interprofessional Service Award to a person who has really gone above and beyond, shown their deep commitment to interprofessional education and collaborative practice. And it is my distinct pleasure to announce that Dr. Kin Lee is the recipient of our award this year. Dr. Lee has mentored, she's facilitated, she's developed curriculum. She's really served the community by bringing together interprofessionality and environmental justice. I could go on and on. I know I don't have time, so I'm going to pass it on to you, Kin, to say a few words. Thank you.
Good afternoon, everyone. First of all, I would like to thank CAIEP for selecting me for the Pagnuco Interprofessional Service Award. This award was unexpected, but deeply appreciated. I am honored to receive this award and would like to thank several people. Thank you to Professor Emeritus Dr. David Mokler for getting me involved with interprofessional education here at COM. Thank you to Dr. Ling Sao for reaching out to me to participate in the former Interprofessional Student Pain Clinic at Northern Light Mercy Hospital Pain Center, and then working in collaboration to develop the FIT program. We actually have a scheduled oral presentation about this program at the IAMC 2024 annual conference in June. Last but not least, my thanks to Dr. Shelley Cohen-Conrad, Chris Hall, and Michelle Cody for all their hard work in expanding interprofessional education here at UNE, and making UNE's IPE well known nationally. Thank you, Shelley, Chris, and Michelle for your help and mentorship these past few years and giving me the opportunity to present at CAIEP's Knowledge Exchange event this past spring. I hope that I can continue to live up to the high standards set forth by Lisa Pednuco with interprofessional education. Thank you again for this amazing award.
Thanks, Ken, and I will pass it on to Chris.
And all of the activities you'll see today are from students pursuing their honors distinction. Today's presentation is the culmination of their group activity, and they will receive honors at graduation due to that, which is a nationally accredited micro-credential.
Interprofessional team immersion, collaborative and patient-centered care. What was the IPTI challenge? Our objective was to work together as a team to collaborate to provide the best patient-centered care for our patient through telehealth communications. The professions represented on the team are social work, pharmacy, occupational therapy, nutrition, nursing, dentistry, medicine, and the faculty and student leaders. We chose the sponges because we felt that represented all the professions.
So for our case study, we had the opportunity to work with Charlotte, a 6-year-old with chronic asthma, and her and her family recently moved from the city to a more rural area where they are struggling with socioeconomic and cultural barriers for support and resources. And they're reaching out to us to navigate this situation a little bit better.
My name's Kiara, and as the RN on the team, my goal was to really gather information about the patient and understand the issues that they were facing, as well as working with my team, both patient-facing and behind the scenes, on how to collaborate and best give resources. My biggest takeaway was that patient needs are fluid, and as a care team, we also have to be fluid with how we work with the family and the patient to meet their needs.
I'm Juan. My role was the occupational therapist, and to add on to what Kiara was saying, yeah, team collaboration was very important. It was important at the start to know what their unique skill sets were, so that you could be able to kind of tailor interventions and how to word questions the right way in sessions. And one reflection that I took away from this was like building rapport with your teammates and also with the client as well to help improve the quality of care.
My name's Heather. I was a social worker and I advocated for the family. I helped provide emotional support for them. I helped them to develop coping strategies and make decisions navigating this difficult situation. I was also involved collaboratively with professionals to address the complex issues, and I acted as a case manager to help make sure the family received the supports that they needed.
Walking away from this challenge, we really understood that empathy and holistic care for the patient and their family is key, and that as healthcare professionals, our roles often overlap, which creates an opportunity for us to be creative and collaborative in how we address the needs and the desires of our patients. Thank you so much for listening, and we're ready for questions.
Great. Thank you, Kiara, Heather, and Juwan for your presentation. It looks like our first question is coming from Provost Mike Sheldon. Go ahead, Mike.
Good afternoon, everyone. Great presentation. I guess my question, if I understood this correctly, this case involved telehealth. Is that correct? And so my question is, in the context of the challenges that you identified for this particular family, how did the technology issue work? We know of some of the challenges here in a rural state like Maine. You know, how did the whole telehealth platform work for this particular family, and how did you navigate challenges that you encountered with that?
That's a great question. I thought actually the telehealth portion of it was the hardest part for me because I'm used to seeing patients in person. So the very first interaction, like I got on and started asking questions before I even introduced myself, because I'm usually in the habit of like going into the room, talking to the patient, then introducing myself. So for me, doing it on telehealth was a total brain switch of how I needed to function and work. And I think we talked a lot about how like reading people's emotions and their kind of reactions to things was so important because we don't have the full body language and whatnot to be able to read off of. So it was definitely a challenge, and worth the challenge, I should say. I don't know if Jawan has any other insight to that.
Yeah, I could kind of add on to that too. I guess like my approach is, I've never been in this situation before, and kind of taking a first time approach would be kind of empathizing with them as well. They're in the same position as us. And it's probably their first time interacting with the multiple disciplines. That could be overbearing. So we kind of approached it where we introduced ourselves, our roles, our names, and what we'd be doing. And then we kind of tailored that to more education, and that's kind of how we approached it as a team. So
We really still tried to have warm handoffs, which I think was the key there in helping our family that we were working with feel like we all were on a team working with them together and not just scattered faces. So that was something that definitely helped as well.
Kiara, I love that concept that you just mentioned of the warm handoff and how it's critical, obviously, in all healthcare, but how even more imperative it might be in this virtual context for people to really make sure that that thread doesn't necessarily get lost. I'm hopeful there'll be more questions from the rest of the room here, but I was curious. You had talked a little bit about what having to build a rapport amongst your teammates, as well as in this complex case that has both a parental caregiver situation as well as the primary client being a child. What was that experience like to build rapport both within your team and then with a pediatric client as well as the primary caregivers for her? Was it hard for you? Was it easy? Did it come naturally because you have a background? Tell us a little bit about that experience for you.
So I think a lot of it, like I kind of mentioned earlier, like you get into this situation and then now you have to figure out, okay, what's the role of nursing, dentistry, social work, and all the disciplines combined, and figuring out, okay, what are our strong points? Where can we place everybody in the right position? They could be a good fit. And then from there, kind of building that rapport as well with team bonding too. We kind of, how we created the name of the sponges was, I think someone might have mentioned something about SpongeBob, and then it kind of just spun off from there. We had help from Dr. Siegel and everybody else. And I think kind of making it lighthearted, joking, not taking it too serious. I think from that point, we kind of had that rapport with each other. We kind of understood where we were coming from, and to kind of position ourselves in a way where we could now approach and kind of tailor a session based off of the information we've gathered in the first session. So we went in there, we introduced ourselves, and I think we started with Sarah. She was the comm student. No, sorry, we started with Kiara. Kiara jumped in there, initiated everything, did a great job gathering information. And then we kind of, like she said earlier, we did a warm handoff with, I think, Sarah, who was the comm student. And it kind of just like, I think it went pretty smooth from there. And we all were able to kind of debrief afterwards and agree. There wasn't a lot of disagreement, but there were a lot of exchanges of like creative ideas and information passed around from each other. So
Hi everyone, I'm Sam Caldwell.
And I'm Emily Susi.
And we're representing IPD's Team 4, the Passionate Pandas, in our presentation of utilizing telehealth in a multidisciplinary approach to treat a patient with allergen-induced asthma. We would like to take this opportunity to express gratitude toward all involved in the making of this project. We couldn't have done it without you, so thank you. A truly shocking statistic describes that children from socioeconomically disadvantaged and minority backgrounds have higher rates of asthma, more frequent asthma flares, higher mortality rates, and require emergency room and hospital care more often than their non-minority and economically advantaged peers. Knowing this information, we believe as healthcare professionals, it's our responsibility to do all that we can to remedy this fact. Our goal for this project is to take a multidisciplinary approach to care for our socioeconomically disadvantaged patient with allergen-induced asthma. The utilization of telehealth made the treatment of our patient more attainable. Charlotte So was our 6-year-old patient who was recently had to move out of their urban apartment into a larger home in a more rural setting. The home is full of allergens that have forced Charlotte to go to the urgent care frequently and even got hospitalized for a couple days. Our care team was directly communicating with Charlotte's parents due to her young age. The telehealth appointments allowed the Sotos to voice their concerns regarding Charlotte's lack of continuity of care, their financial hardships, and concern with the current pharmaceutical approach to her treatment.
So for appointment 1, we had the nurse and public health official go in to get some background, as well as the physician and dentist to answer any pressing issues. For appointment 2, the first half of the appointment, the nurse, physician, and occupational therapist went in to answer any more questions and provide background information. And the second half was the occupational therapist and community health worker, as well as to recommend any alternatives that Charlotte can utilize. So our biggest takeaways was teamwork. We learned how to work as an interprofessional team and to remember what our areas of expertise are. We collaborated behind the scenes as well as in the appointments to give the best information we could. And continuity of care, we wanted to ensure that we continue to have someone that the Sotos would know for each appointment, whether it was a nurse or physician. And that is all. Thank you.
Great. Thank you so much, Sam and Emily. Anyone have any burning questions at the moment? I, of course, do and will. So you can bank on that. So I was curious how your team went about deciding who went in for those different appointments. It looks like there was some decision making that you made from where you started, and it looks like a couple people were repeats. And sort of how did your team go about deciding who went in to participate on the telehealth session?
Yeah, so for the continuity of care, like I mentioned, we wanted to make sure that each individual appointment, there was someone there that they had previous experience with. So a lot of times it was the nursing student who went in, and she often introduced whoever she was going in with, because we decided to start out with the public health official, which was myself and the nurse, to get all the background information that we could get. And then we wanted to address all their pressing questions because, like any mother would, she had a lot of questions in regards to all the medications she was on, the weight gain, a bunch of different things that they wanted to address. So we focused on splitting it up into these groups so that we could I lost my train of thought. I'm so sorry. We could address each individual need while also getting every profession that we could into the appointment.
That's great. The next question I have for you, and again, please feel free to raise a hand or jump right in there, audience, if you wish, but how do you feel like this telehealth experience might prepare you for your future career, or will it?
Yeah, so I worked with telehealth before during COVID. That's when I have a background in medical assisting and I trained during COVID. So I have a lot of experience with telehealth. And so going into it, I knew what to expect. But overall, I think it's helping my profession because it's going to allow me to communicate better because I'm not very good at communicating over Zoom. I am a very reading body language type of person. So it was interesting to say the least, especially for the OT student. That was one thing that he mentioned was he relied on body language. So yeah.
That's great. Thank you. And then last question, if you don't mind answering quickly, is how did you feel about the 20-minute time limit?
Oh, it was a great time. No, we struggled with it. The first appointment, it was supposed to be split in half, and we ended up taking the entire 20 minutes for background information and just doing it between those. It was difficult to stay in that 20 minutes.
Well, thank you for your honesty and candor about that, Emily. I'm sure you weren't alone in that.
As part of the Public Health Interprofessional Training Program at the University of New England, we were tasked with developing a fictional case and investigating potential public health interventions. So today we are discussing a case of gestational hypertension and diabetes. Our patient is currently 28 weeks pregnant with her first child, and she has gestational hypertension and diabetes. She has had hypertension for the past 4 years and was diagnosed with prediabetes 1 year ago and now has diabetes. She has previous opioid and alcohol use disorder, she is a former smoker, and she is currently obese. Some of her behavioral risk factors include the fact that she is unable to maintain a regular exercise schedule and consumes a lot of cheap and convenient fast foods. She feels as though she is unable to implement lifestyle and behavioral changes to control her diabetes. She works as a CNA on the night shift 4 times a week, lives alone, although sometimes her on-again, off-again boyfriend will stay with her, although he has a history of domestic violence. She does not live within walking distance to any public trails and does not own a car. Fortunately, she does have some protective risk factors, including the fact that she has full health insurance coverage and a comfortable annual salary. She walks to work every day, has a supportive sister who lives approximately 45 minutes away, and has overall good family relationships and strong connections with her coworkers. She identifies as African American and female and is a Somali immigrant. Some of the potential interventions we identified include assisting our patient with applying for the Special Supplemental Nutrition Program for women, infants, and children, which provides supplemental nutritious foods for patients who are pregnant. After pregnancy, we would assist our patient in applying for the Supplemental Nutritional Assistance Program, or SNAP, which is essentially the same as WIC, although not for pregnant patients. We would also provide her with information about the YMCA in the Auburn-Lewiston area, which would allow her the opportunity to meet others in the community and take advantage of the fitness classes. Additional interventions include identifying Somali support groups, for which there is one in Lewiston, Maine. This would provide her with an increasing sense of community. We have also identified the Catholic Charities Refugee, which assists with employment, completing job applications, and assurances of basic needs. We also would provide her with information on Caring Unlimited, which provides resources and counseling services for victims of domestic abuse. Thank you.
Great. So Tessa, Drew, Ariana, if those of you in the room can just kind of wave so we know who you are. Okay, great. Thank you. So we know we got a couple folks here. Feel free, like I said, raise your hand or just unmute if you've got a question. I was curious, given just the complexity of the variables, both positive as well as potentially some challenges, how did your team manage prioritizing for this client?
That's a good question. I think that some of the things that we felt were the most important to manage were the things that were going to impact the pregnancy right at this moment. So obviously figuring out the hypertension and diabetes, and then sort of some of the other things that seem to be, although very important, but maybe they could be handled at a later date. I think we chose to implement interventions that were going to take care of what we felt was the immediate problem.
My next question for you would be, it seems like you found some wonderful resources in the community to meet both her immediate needs and potentially future needs. Do you have any tips and tricks for the rest of us as we try to find that balance for clients to not overwhelm them with all of the options all at once? Did your team have some tips and tricks for the rest of us? Or anyone in the audience?
Yeah, I was going to say, I can chime in. This was sort of not a totally fictional case, but we never actually like implemented it to like this person. But I have had to reach out to patients before to like let them know of resources that exist similar to this, where like they really have a lot of needs, and there are a lot of resources that we can give to them. And I feel like how I've approached it with my patients before is seeing how they come in that day, if they have expressed any specific concerns, like sort of dealing with that in the moment, and then advising them on a resource for that versus like giving them a list of all of these things, because in my patient's experience, like their life is already overwhelming. So giving them so many is an additional overwhelming factor. So for me, in my experience, that's sort of how I've done it, is sort of over time as you continue to build that relationship, give them more and more resources as you go.
Go ahead, Emily. Please jump in. Thank you, Drew.
Sure. Yeah, I guess as a team, there's just so much that was going on in the background. Were there, and maybe I missed this, but when you think about the other people that you could have tapped, were there other people on that you would have liked on your team from different professions? Or did you feel like, let's say you had who you had, how did you feel about the synergy of the types of roles that you all have and how they overlapped? Was there any observations that you took away from that in terms of things you were surprised by or, not surprised by?
I think that one thing that would have been really helpful would it be to have also a social worker. I think that would have been another just great person to have on the team. But overall, I thought we, managed very well with our fictional patient. And I think we came up with some really good ideas. But, definitely the more help, the better.
Mm-hmm. And what about your roles? Did you feel like, were you surprised by anybody's roles or the areas in which you might have overlapped?
I think that we all sort of put our brains together. And like for me as a dental student, we didn't really address any dental focus needs, but we are all healthcare providers and have certain experiences with certain patients. So I think this patient in particular didn't necessarily wasn't totally directed at being more focused towards one health profession or another. We just all shared our experiences and chimed in where we could to help find potential interventions to help them in the future.
That's great. I can say one of my experiences facilitating a team that had a dental student, you all possess an amazing skill to calm down anxious people who might be afraid of sitting in that dental chair. And just that demeanor as a whole, it transfers to anything that you do. And so you might not think of it as a skill that you're trained in per se, but that aspect of your profession, I always think I've always just respected. So I think, sometimes when you show up and you feel like there's nothing you can do because it's not a problem related to your field, I think that these are the types of experiences where you realize like, oh, wow, like brush my shoulder off. I got this. So nicely done.
That's great. Thank you so much, Tessa and Drew, for sharing your insights with us.
Hello, everyone. Thank you for listening to our interprofessional collaboration exercise here, where we will be analyzing and addressing some of the health disparities in rural Maine, specifically surrounding a case study that was created for a hypothetical one for patient Naomi Alice. So Naomi is a 32-year-old Black Somali female with a history of chronic migraines, rheumatoid arthritis, hypertension, and generalized anxiety disorder who presents to the emergency department with an acute headache for 2 days. The patient has been experiencing some elevated levels of stress and exhaustion, as well as some malnourishment and some potentially hypovolemia and dehydration that was identified in the ED as some potential exacerbating factors. It was also noted in the ED that she poorly manages some of these chronic medical disorders with medication due to some limiting factors, and she has a intermittent relationship with her PCP.
So I'm actually going to skip over this slide because a lot of it is covered in our framework, which is the slide after this one. So we wanted to make sure that we were looking at all of the factors that can be affecting her health, which would include the built-in environment. She lives in a rather rural location. Her personal self-influencing behaviors, such as smoking daily and having a low level of exercise and not having the best nutrition. We also looked at healthcare status affiliated factors like having poor access to a PCP, as well as social, cultural, and economic factors. On the side, we also looked at some modifiable and manageable risk factors, some that were already covered, like hypertension and generalized anxiety disorder, and some that are non-modifiable, like her family history of hypertension, RA and GAD, and some other protective factors as well.
So in terms of applying interventions to this patient, we did have some acute interventions that we identified that we could initiate in the ED, the first and foremost would be medical management of her acute migraines. So we had a number of medications and some IV hydration and some electrolyte corrections that we could do to help her with her acute presenting symptoms. We also wanted to make sure that we provided her with a note work to mitigate any challenges surrounding her, any work that she missed or would miss over the next couple of days that she may have to recover. And then also, given her malnourishment, even though that was largely influenced by her busy schedule and her job, we did want to make sure that once her nausea and her migraine improved, that we gave her some nutrition there in the ED, and then also offered discussion with a social worker about some maybe acute diet modifications that she could consider to prevent this from occurring in the short term.
In the long-term interventions, we are interested in having the patient consider enrolling in Maine healthcare. It has a more socially supportive package. It has less co-pays and would offer some more social services for the patient in delivering care at home. One of these services would be exploring telehealth providers for a primary care provider or a therapist to help manage the patient's generalized anxiety disorder. We would also be interested in conducting patient education with a nutritional specialist, as would be recommended and referred to by an ED physician. We are really focused on informing the patient on factors that could be exacerbating their migraines and how this could be prevented and improved by managing nutritionally, hydrating, and addressing those well-rounded factors. Lastly, we would be interested in conducting and exploring the opportunity of doing osteopathic manipulative medicine treatments. Some research has demonstrated that treating OMT migraines has been effective in the acute presence and also long-term prevention. So this would be something we would explore. There is a free clinic here at University of New England College of Osteopathic Medicine that a patient could come and have monthly or bi-monthly treatments.
Some other considerations that we were looking at were prescription deliveries. Since our client lives in a relatively rural area and has poor access to reliable transportation and to her PCP, deliveries can be made through Maine Health with any prescriptions prescribed by her PCP or therapist for free. We were also interested in looking at cultural community engagement. There is a group in the greater Portland area called the Somali Community Center of Maine, and they offer a lot of different resources for immigrants, such as financial health, health literacy, and assistance with housing.
Lastly, our key takeaways as a group is that the most important thing to do is have a patient-centered approach. We want to tailor a personalized care plan with a multidisciplinary care team to take care of all the patient's needs and do an in-depth review of the patient's social determinants of health. There are so many factors that make up and contribute to a patient's health and well-being, and to do that as an integrated multidisciplinary healthcare team, we have to consider all of them. Lastly, we really want to emphasize the importance of establishing rapport and trust with populations, especially immigrant populations. We want to continue relationships with them and create an open line of communication for long-term success and care. Most importantly, we want to approach each encounter with cultural and social humility. Thank you so much for your time.
Thank you. So I believe that we have all three of the presenters here in the room. So just give a little wave so people know who to look at. We just have a couple of quick minutes left before we wrap things up. I'm curious if any of you feel like you could share what you're going to carry through to your career most from this interprofessional opportunity with FIT. What are you taking with you in your backpack as you leave UNE?
Well, definitely the fact that it takes an entire team to care for a patient, and we would have valued even more specialties within this, hypothetical case. Typically it's nursing, it's PT, it's physicians, it's social work. There's so many factors contributing to it, and then social community support. So I think the big picture is that whole person health takes a whole team with multiple specialties to approach and improve well-being.
That's great. And the last question I'll ask is, were there any surprises in the resources for our community that you find? I know sometimes when you peel back the layers and realize what a complex individual like this situation needs, that sometimes we have a lot more or a lot less resources in our community. And I'm just curious if your team found anything notable in your trying to support this client.
What I found the most surprising was the resources for specifically Somali immigrants in the greater Portland area. I know that Maine houses a lot of different immigrants from Africa, and I was really surprised that they had the in-depth resources that they had. Like, it wasn't just like housing and finances, it was also like health literacy, learning English, and just, I thought it was a really great resource, and I was really surprised to see it.
Well, great. Thank you all for being here today and attending and hearing all the amazing work that's done. Thank you for those of you who hung out in track 1 today, whether part of the time or all of the time. I hope that you learned a lot from all the individuals and facilitators and all the amazing IPE work that's impacting our direct UNE community, but our community at large.
Great. So this is our first presentation, the Amiable Avengers. And they are going to talk about their experience in our interprofessional team immersion. Thank you, Sarah, Rose, and Jessica. And thank you to our faculty who supported them, Bree Fortin, Nancy Jo Ross, and Pat Kokomo. So let's get started.
Hello, everyone. Today, we are going to be talking about managing pediatric asthma through interprofessional telehealth collaboration, where effective collaboration in an interprofessional healthcare team is possible, even in telehealth. We participated in the Interprofessional Telehealth Immersion Program, and we are Team 2, the Amiable Avengers.
So for the presenters here today, we have myself, Sarah Shaw, a nursing student, Jessica Jawhar, a medical osteopathic student, Rose St. Paul, a dietetic student, and the other team members from this experience included Libby Bresniak, a dental student, Brianna Burke, a pharmacy student, Rebecca Corbett, an occupational therapy student, Hilda Everson, a physical therapy student, Carrie Grace, a dental hygiene student, and Lloyd Seeley, a medical allopathic student.
The IPTE Challenge features students from various health disciplines, and the IPTE simulation involved understanding professional roles and responsibilities, communicating openly and respectfully, establishing common goals, and respecting diversity, sharing knowledge and expertise, and developing a patient-centered care plan through interprofessional collaboration.
For this simulation, our client was a 6-year-old patient named Charlotte who was diagnosed with allergen-induced asthma at the age of 4. Currently, her primary symptoms consist of a persistent cough, becoming easily winded and fatigued. Her parents, Simone and Daniel Soto, were distressed about her condition, so they turned to their community health team for answers.
Team collaboration. Through teamwork, high-quality care was provided for Mr. and Mrs. Soto. Additionally, actionable and sustainable goals were developed to address the overall health and well-being of their 6-year-old suffering from asthma. And today, a few students from the interprofessional group will speak about their experience. Here's a quote from one of our facilitators, Professor Brianna Fortin, Nutrition. Team 2 worked so well together, and by the cohesiveness of the care they provided with Mr. and Mrs. Soto, it was clear that they trusted each other to provide the input that was needed for this case. Empathy was also a strong suit of this group from all professions.
Thank you, everyone, for your time, and we are opening the floor for questions. Thank you.
Great. That was great. So, who would like to begin by asking any questions? Well, I will begin. Because over the last several years, telehealth has become really something that all of us as health providers need to know how to work with. And because you did this case study with the family, Mr. and Mrs. Soto, I'm really curious about your experience of telecollaboration, what you really learned in the experience of working together using a telehealth modality.
I don't mind starting. Hi, everyone. I'm Jessica. Um,
and I'm from COM, so an osteopathic medical student. I think that's a really important question, and I think we all learned a lot overall. I think the biggest thing is through telehealth, it's very hard to communicate well just because you're not there. It's hard to see the nonverbal cues that we learn about. But through that, it's a good experience. Like this was a great experience to learn about that for the future, for our future patients. And I think it was also difficult not being able to speak with the patient who is a pediatric patient and being able to like open that trust from the beginning just for not being in person because there was a lot of things going on in the family and it took a lot of time to establish that trust because I think through telehealth there's a disconnect, like a human personable feeling. But with that said, because of like us also working behind the scenes, we were constantly communicating as like an interprofessional group, always thinking who's able to like contribute their skills in this part of the case, who thinks they're confident in like being able to tackle this. And like through Rose, we were all able to like also learn motivational interviewing. And so that's where we had to adapt different skills, especially for telehealth, and just like approaching the patient in like a more like applicable way. So I hope that kind of helped.
I'd also like to add that just through this whole experience, we were able to see that even though it's, relying on telecommunication to really collaborate with each other, it can be done. And it's all about respect. It's all about really learning the core of what everyone does on the team, and really playing on those strengths to service the patient, well, the whole family, because if the parents aren't 100%, or if they're not healthy, or if they have these mounting issues that they have to deal with, as we saw, they moved to a new neighborhood, they were having financial issues, like we really had to approach it in a holistic way. And I think that all of us understood that, and I think that that's what really strengthened our collaboration efforts to really provide the care that the family needed.
I have a question
agree.
for the group. Oh, go ahead, Sarah.
No, that's okay. No, I was just wanted to mention too, like I definitely agree with Jessica and Rose's points. Like, yes, 100% sign off on that. But I think one of the big challenges with telehealth is just letting the patient know, like, even though we're so remote from each other, like we're still here for you. And I really had that at the forefront of my mind through this whole experience, especially from the perspective of nursing. So to keep that going, I even started our introduction with our family of, just saying like, what are you hoping to gain from this? Just to really like let them know we are here for you. We want to help you succeed. And yeah, so I think that's really important too, because a lot of that can get lost in communication, especially on telehealth.
So this one is supporting health with harm reduction, Cumberland County Jail Wellness Bags. And the team includes Lauren, Riley, Sarah, and Caitlin from COM, and Sarah May Rose from Pharmacy, and Caitlin from Occupational Therapy. And thank you to Chris Bates Withers, Chris Hall, and Christina Stewart for being facilitators and mentors for this group. Take it away.
Hello, today we're presenting our project titled Supporting Health with Harm Reduction, Cumberland County Jail, or CCJ Wellness Bags. The purpose of this project is to support the recovery, reentry, and overall safety of residents departing the CCJ and offer supportive resources to the correctional officers at CCJ to reduce stress and increase overall well-being based on the high prevalence of overdoses from individuals reentering the community. We're an interprofessional team of students and faculty from multiple programs at UNE.
We held a focus group with CCJ residents in February. Their feedback was vital to the implementation of this project and helped us create a list of supplies to include in the harm reduction kits. We collaborated with community organizations that provided donations, including wound care materials, bus passes, water bottles, and clothing vouchers. We partnered with the College of Osteopathic Medicine Addiction Medicine Club to create wound care kits and write handwritten cards to residents that were included in the harm reduction kits. We held a wellness event for correctional officers in March and led a harm reduction kit packing event in April at CCJ.
For our correctional officer wellness event, our team traveled to CCJ, where we handed out wellness bags to the correctional officers to provide support and improve their overall well-being. The wound care and harm reduction kits will be distributed to residents of CCJ upon their release. Our team packed wound care supplies to treat wounds and prevent infectious disease. We specifically included these supplies to combat the rise in xylazine, a large animal tranquilizer that is now being mixed with substance supplies and is associated with severe, rapidly spreading wounds. It is our hope that these kits will reduce overdose fatalities and incidents, support recovery, and promote the overall well-being of those re-entering our community. Our team met with a focus group of 4 male residents who use substances or are in recovery. They provided feedback on items and resources that would specifically support them through their first 24 hours upon re-entry. We use this information to create a resource packet and include specific items in our kits. In total, we packed and distributed 96 wellness bags for correctional officers and 200 wound care and harm reduction kits that will be distributed to residents upon their release from CCJ.
During this project, we learned to work together as a team and brought different perspectives and approaches to harm reduction and ways to support this population. Our next steps, we would like to continue fostering relationships with CCJ and gain feedback on the kits, maintain and expand community partnerships, continue our efforts for student recruitment to maintain sustainability of the project and bring in more health profession programs, and apply for more grants to support creation of future kits.
This project was grant funded. We would like to thank the CCJ staff for their collaboration and community organizations for their donations. Thank you to the UNE faculty and staff who supported our team.
Fantastic. So, do we have questions for the group? I always start, and I have a real fondness for this group, but I'm going to let Mike Sheldon start.
Maybe I'll go ahead and start. My name's Mike Sheldon. I work in the provost office. And I guess I'm curious about one of your next step, because you mentioned expanding partnerships with other community members and the intervention, what you had worked on, there's this one-time thing and you want to sort of know the impact of that. What are your thoughts about that in terms of sort of ongoing support? And what are the other community partners that you'd want to connect with as it relates to, more ongoing support in this context?
I can start off. Hi, my name is Lauren. I feel like continuing to foster the relationships we've had with community organizations that we reached out to and who are really excited about supporting this project. So we had donations from Portland Metro, and as well as the transportation system in Biddeford, Saco, Wood Orchard Beach. They donated bus passes, so continuing to foster that relationship. In a focus group with 4 residents, they had mentioned that the bus passes are super important to be able to get to where they need, since the jail is located on the outskirts of Portland, not right near the resources they need. We also, a new donation we had this year was from Goodwill for vouchers for clothing. So I think continuing that relationship and also building relationship with harm reduction organizations, maybe expanding to organizations like the Church of Safe Injection. We partnered with the Portland Needle Exchange, so they are the ones that really support us in creating the wound care supplies, just for overall first aid and with wounds for xylazine. So those are a few, but just any organization that we really feel like can help and would be willing to donate.
Hi, my name is Riley. I had a follow-up to Lauren's answer as well. She did mention that we have a relationship with Portland Needle Exchange, and actually in the resource packet that we give to residents leaving CCJ, there is a little card that we include with a map, and it lets them know how to get to the Portland Needle Exchange, and they will kind of supply anything that they need. And they also do some blood testing as well. I think they do HIV testing and some testing that they may need as well. So that's kind of more longitudinal care. We can send them to Portland Needle Exchange for any sort of issues that they may be having, and to get more wound care supplies if they need that as well.
Great, thank you. Other questions?
Shelley, can I ask a follow-up?
I think I'll let you, yes.
So for any of you who this was new to, I'm kind of curious if any of you had conflict, going into this that, I don't know about this. There's been literature written and opinions on both sides of whether this, how this works. And if you were conflicted, how did you resolve that conflict?
Hi, my name's Kate. One thing that I was a little bit nervous about was the environment and like the support that they get in the jail as a resident. But that is shifting to be more supportive and to be more inclusive of the harm reduction kits that we're passing out. And so that was a positive impact that this had on me.
And just to quickly follow up, my name's Sarah Mayrose. I'm from pharmacy. I think the reason that we all got into this was because we knew that there is an issue and that there is something like with the environment and the some sort of like the hostility that can be there. We wanted to combat that. That was really the biggest thing that we were working towards. So I think that was the biggest reason that we got into this project.
So our third presentation is from FIT, Public Health Problem Solving Paradigm and Interprofessional Team Training. And this is Mr. Pierre and type 2 diabetes. And our student team are Andrew, Ariana, Shell, and Kathrika. And our faculty mentors are Dr. Ling Sao and Kin Lee.
Hi everyone, we are FIT Team 2. My name is Andrew and I'm a second year at the College of Osteopathic Medicine.
My name is Ari, and I'm an undergraduate medical biology major.
My name is Chell, and I'm in the Masters of Public Health program.
I'm Kartika Singaravelu from College of Osteopathic Medicine. Moving on to our case, Mr. Pierre presents to the mobile frame farm worker outreach clinic of a local federally qualified health center to check his blood pressure and reported a prior diagnosis of hypertension for which he is not currently medicated. Upon examination, it is discovered that Mr. Pierre has uncontrolled type 2 diabetes with an elevated levels of A1C and PSA and also hypertension.
So moving on to our framework for some protective factors, we have that he does see the clinics in both Florida and Maine. He has access to a local food bank and has strong social connections with family and friends. He also displays consistency in attending these mobile health clinics, and he is not a tobacco, alcohol, or drug user, and he does have reliable transportation of his own car. For some risk factors, he often resides in a food desert, has unmet medical needs because of insurance status or language barriers, and has poor worker housing conditions. With this, he also has limited income, no medical insurance, and does not currently qualify for Maine Care or SNAP because of existing benefits in Florida. And he also lives in close quarters when at the worker housing conditions and eats a highly processed poor diet and is often exposed to heat, UV radiation, and pesticides.
So we identified 5 different categories of interventions for Mr. Pierre, starting with medication counseling and side effect management. The main part of medication adjustment was switching to Januvia, which is a different medication for diabetes that has fewer side effects, which will help with compliance. We also recommend Merck Helps, which helps with cost of Januvia, and a PO box and other sites for cheaper medications. We also recommended applying for residency in Maine because Mr. Pierre would then be eligible for Maine Care. Also connecting Mr. Pierre with a patient navigator who can assist him with transferring residency and benefits from Florida to Maine.
We also identified some opportunities for telehealth use, which could improve his adherence to his medication and improve his continuity of care, regardless of where he resides geographically during the year, and allow communication between his providers, as well as some opportunities for patient advocacy, considering the inadequate housing which he finds himself in as a migrant farm worker on many of these farms. And so bringing in organizations such as Farm Worker Justice and the Department of Labor, as well as advocating for better interpretation access, which is a legal requirement for many of these healthcare centers. Thank you so much for attending our presentation.
Congratulations, that was great. So do we have any questions? Well, I have a bunch of questions. So I can start. I'm really interested in, there's a complicated case, and I'm really curious what you learned from each other in working this case together. And the second question, just in case I don't get it in, is what you learned about this population, which isn't spoken about very much in your curriculum. So I'll throw those two questions out to the team, and whoever wants to respond, that would be great.
I can start. I feel like one of my favorite parts about working in an interprofessional team of this nature was just seeing my own blind spots. I have a public health background, and so there were clinical things or just different things that were coming in from different members of the team that are just completely not in my wheelhouse. And it was really exciting to be able to interact in a team setting where people have different experiences, different educational and different personal experiences that they're able to bring to the table to contribute in that way.
Thank you. That was great. Other members? Andrew?
Yeah, so kind of going off what you and Shell just said, this was a very difficult and unique case. And so it definitely highlighted the importance of needing a multidisciplinary team to kind of approach it from all different angles. And so that was kind of my biggest takeaway, is that I realized like every member of the group had different strengths and was able to, as Chell said, like see or like help contribute to blind spots that, our disciplines kind of teach us or, narrow our focus into, but then other members could contribute in different ways. And so I feel like with a case like this, it really, again, highlights how important it is to work together in teams and, improve the overall patient outcome by approaching it in many different aspects. So it's great.
Thank you.
I think I'll touch a little bit on also the you've mentioned the population. It's a very invisible population, particularly here in Maine. It's something that I personally have a lot of experience with, and I feel like that was one of the strengths that I brought to this project, was just the knowledge of that population. But again, like Andrew was saying, everybody kind of fills in with their own expertise and contributions. But I think that one of my main goals in presenting this as a case for us to discuss was to shed light on this population, because it is such an invisible and not widely discussed population in the medical field.
Well, Jill, we appreciate that, highlighting a really important population for health providers to be thinking about and working with. So I'm thrilled you brought your knowledge into this discussion. Thank you. All right, I think we're coming to our final presentation, and this is also from our FIT group. And this is looking at tuberculosis, another topic we don't discuss very much, and the public health paradigm. And this is Evan, Emily, Ava, and Cindy from a physician assistant, two from public health, one in the graduate program, one in the undergraduate, and from osteopathic medicine. And again, thank you, Dr. Sal.
Good evening. This is Team 4 with the Public Health Problem Solving and Interprofessional teams, and we're providing a theoretical case study of acute tuberculosis in Portland, Maine. Our patient is DW, is a 28-year-old social worker who works with unhoused populations. And he's presenting with acute tuberculosis after a 4-week history of persistent cough, chills, night sweats, fatigue, and shortness of breath with activity. He's also lost 10 pounds unintentionally over the last month. He thinks that the high stress of his work is what is causing these symptoms. Nothing makes it better. He denies chest pain. He doesn't own a thermometer, so he doesn't actually know if he has had a fever. His past medical history is exercise-induced asthma, chickenpox, bipolar disorder, and HSV. He takes Truvada for PrEP against as a HIV prophylaxis. He has a albuterol inhaler and takes valcyclovir for HSV flare-ups. He has also had a tonsillectomy in the past, and no known drug allergies. Social determinants of health. He lives alone in a nice 1-bedroom apartment in a safe area of Portland. He is economically stable. He doesn't have to worry about money for rent and food. For his education and employment, he has a master's degree in social work, and he's currently employed by Maine Health. He has a close social support system. He plays on an LGBTQ volleyball team, has a good relationship with his immediate family, and has several close friends in the area. He identifies as a non-Hispanic white male. These social determinants of health are further subdivided into individual, family, friends, community, and environment. Starting in the smallest circle individual, we have his age, his education, his past medical history. Under family and friends, he doesn't own a pet. He's single. He doesn't have a romantic relationship. He has a close relationship with his immediate family. Under community, the friends he has that he meets up at bars, the kickball team that he's in, his friends and coworkers. Under environment, we have Portland has generally good air quality. It's accessible with a car to grocery stores, and he lives by himself in a neighborhood that has good outdoor space for recreation. So for some of our interventions, first and foremost, medical treatment. He's going to need to be treated with a combination of antibacterial medications, and he's going to need to isolate for 7 to 30 days until the infection is cleared from his sputum. Because he's going to be isolated for so long, we want to make sure that he has telehealth options. And given his history of bipolar disorder, we think it's important that he looks at some apps that focus on stressor therapy or telehealth therapy options. Given his lapse with PrEP recently, we think it would be a good idea for him to talk to his primary care provider about Apretude, which is an injectable form of PrEP, and to maybe look at transferring to Franny Peabody or Planned Parenthood for treatment. The state's going to end up providing him case management as well as food assistance and direct observed therapy. So a nurse will come out and make sure that he's actually taking his medications. As far as his work as a social worker, we think advocacy would be a good idea, fighting for more social workers at Maine Health, as well as getting involved in education of new social workers. We also think that since he has a work-related exposure, that he could apply for workers' compensation. If he still is running into some financial problems, GoFundMe would be an option to crowdsource, and then using things like Uber Eats or DoorDash or Instacart for groceries. Thank you very much.
I want to applaud too. That was great. I was really interested in this case because I don't know what the pervasiveness of tuberculosis is in Maine. So I was really curious about this case and what you learned about it as a team. That's my question.
I can start. This is Emily. I am in the public health program, the master's program. And I just wanted to note a couple of our team members may not be able to chime in. We had a couple last minute emergencies come up, but I see myself and Ava are here, so hopefully we can answer the questions as much as we can. I in public health, and I also am trained in family medicine as well. I am seeing the rise of tuberculosis in Maine right now. So this is a very relevant topic to be discussing right now. I can't cite numbers of prevalence off the top of my head, but I do know that this is a growing issue, especially with among people experiencing homelessness and in shelters. And there, with the recent migration of new Mainers, there is a high prevalence of latent tuberculosis worldwide. And so with a lot of those shifting demographics, there's just a real need for screening and treatment. Obviously, this is active, so it's a bit of a different situation than latent tuberculosis, but I'm glad that we chose this topic, so it's very relevant to what's going on in the state right now. And Ava, I don't know if you have anything to add, but those are my 2 cents.
Hi everyone, my name's Ava. So I'm actually from Long Island, New York, and right outside the city, there isn't that many unhoused people, so I don't really know the prevalence over there, but over here, they're definitely in Saco and whatnot. There's definitely a large population of unhoused and whatnot, so I believe that it does affect a lot more people in this area of Maine than it does back at home for me. I'm not, like Emily said, I'm not sure of the numbers and whatnot, but it definitely seems to be a little bit more prevalent in this area rather than northern Maine or stuff like that.
So our presentation is from the Public Health Problem Solving Paradigm and Interprofessional Team Training, FIT.
In our case, we will present an interprofessional approach to managing type 1 diabetes in pregnancy through a complex patient case utilizing the public health paradigm. The case was put together by Allison Key, Emma Mather, Erin Mazaruki, and Megan McAuliffe. as a collaboration between students from the College of Medicine, the undergraduate medical biology program, and the undergraduate public health program. Our patient, Amy Jensen, is a 34-year-old female. She was diagnosed with type 1 diabetes at 11 years old and is currently 4 months pregnant. She is married to a supportive partner and serves as primary caretaker to their 3-year-old daughter, as well as her wheelchair-dependent mother. Recently, her husband changed jobs, causing the family to temporarily lose access to health insurance. She is currently applying for Maine Care. Currently, the family is under financial strain as her husband's new job has higher potential for earning, but current income is less during his training than they previously relied on. She is working as a waitress to help bridge the gap. The financial strain and the stress of working while also serving as a caretaker has limited their access to healthy foods, and now the family is primarily consuming frozen or packaged foods. Amy has a strong support system of family, friends, and a supportive workplace. Risk factors affecting Amy are shown on this slide. At this point, the biggest concern with her health is the lack of prenatal care. Some protective factors in Amy's case include her support system, living in a safe and walkable community, and her eligibility for programs like Maine Care and SNAP. This diagram shows how those factors interconnect to affect Amy Jensen. Both protective factors and risk factors affect each other and her in unique ways. For Amy, accessing SNAP or WIC to improve access to food will be beneficial for her pregnancy, her diabetes, and her overall health. She is eligible for SNAP due to her financial status and as a caretaker for her mother. She is also eligible for WIC through her pregnancy. Amy is being provided information on utilizing MedAccess to access her insulin. This program is available for anyone who needs it. The Insulin Safety Net program will also help Amy by capping her monthly insulin costs at about $35. While she is on Maine Care, her insulin costs are covered, but should she receive insurance through her husband again, she will be paying less in medications. Amy will also be able to access free transportation to her doctor's appointments through Maine Care, a service that will help to support her ability to receive prenatal care.
All right. Well, I guess I'm the official facilitator of this session, and we have about 3 minutes, and I'm kind of curious. Well, first of all, does anyone have any questions for the group about the work that they did? Do we actually have any group members here? Who is here? Can you unmute yourself if you're a group member and just kind of claim your presentation? Anybody?
I think all 4 of us are here.
Excellent. Hi. So, okay. Well, if no one has a question, I have a question for you. You came from a couple of different perspectives, social work, public health. How do you each see yourselves or your profession helping this particular individual with all those interconnected factors that you talked about? And I think, Erin, you're on my screen, so maybe you want to start.
I'm a public health major, so I was like looking at it from that standpoint. So I was like kind of like looking at like finding programs for her like SNAP and WIC, and then we also just like obviously wanted to get her help for like her pregnancy and stuff. So then we looked at like things that she could do for her insurance. So we kind of like, I think we started with like finding like smaller programs and then like broadened it from there.
That's great. How about someone from a different profession? How would your profession help this specific individual?
Coming from the College of Osteopathic Medicine, through the PHIT program, we had the opportunity to meet with one of the social workers that's embedded into a clinics, outpatient clinics in Maine, through, I think it's through Maine Med. And so I think making sure to refer into those services as her like physician would be very important, just because there are a lot of outside factors that are kind of inhibiting her ability to access care.
Absolutely. And I'm glad you also brought up the social work perspective. I don't know if the social work student is on this, because I'm guessing, and this might be a deeper question, that providing, and I loved your framework of all the interconnected resources for her, but kind of convincing her to access these or helping her see these? I don't know, the social work student, did you talk a little bit about kind of how you would approach this individual with, to help her kind of feel good about accessing these or feel comfortable with that?
I don't know if we actually have someone that is like
Oh.
social work. It says that it was me, but I think that it was wrong.
So this is the public health problem-solving paradigm and interprofessional team training, FIT, Team 7. Welcome, Team 7. And we're going to hear their video about a team approach to improving mental and physical health, a patient-centered framework.
So we have our patient introduction here. Our patient's name is Aura Lewis, 35-year-old Caucasian, they, them pronouns. The patient is on medications, which are bupropion, as well as Botox injections. And past medical history, the patient had 2 concussions, 2013 and 2023, broken wrist at the age of 5. Some of the patient's comorbidities include hypertension, obesity, depression, dystonia, diabetes, and alcohol use disorder. The patient's allergies are shellfish and latex. So some of the patient goals we have for them are reduce the frequency and severity of dystonic episodes, as well as improving functional ability. We would also like to improve their mental health and well-being and medication education. We would also like to achieve healthy weight and blood pressure. And lastly, we would like to achieve and maintain sobriety for this patient. So those are some of the goals we've set for this patient.
This is a quick patient-centered framework that we created for our patient, Aura Lewis. Here we've included some pertinent co-occurring conditions, such as their new and untreated diagnosis of stage 1 hypertension and obesity. We've also included an older diagnosis of dystonia, as this is one of their diagnoses that we'd like to address with this patient, as to try to find a more accessible and efficacious treatment plan. We've also included here their co-occurring and anxiety and depression, as this has greatly impacted this patient's health outcomes. Some individual factors that we felt were really important for this patient that the patient has made clear to us that they would like to address is their social independent alcohol use. Something that we'd like to address with this patient is potentially finding community that doesn't revolve around alcohol and events that maybe don't have alcohol as the center point. On a different note, we also would like to address with this patient how their dystonia has been affecting their sexual activity as well as their ability to do art, because both of these things are greatly impacting their mental health. We would also like to address with this patient the accessibility of finding groceries, as well as spending time to move their body and exercise in a way that feels good to the patient. These are both things that we'd like to make a plan with the patient and work with the patient to find solutions that feel best for them. Lastly, we felt in this section that it was important to bring up that both of their parents struggled with alcohol use disorder as well, and that they separated, and recently Aura separated from their partner, and this has presented many difficulties as well as limiting their transportation.
There are 3 channels of interventions that we hope to explore: community, access to care, and identifying next steps for treatments. Community starts broad at the social determinants of health by identifying community and social engagement that does not center around alcohol and helps connect our patient to important parts of their identity. Such organizations include the ECC, the Equality Community Center, Kindling Collective, and Maine Transnet. The access to care is currently limited by the patient's financial situation. By identifying the patient's eligibility for Maine care can potentially help them have greater success and access to needed medications and treatments. We can also identify the need for a case manager or social worker that can help the patient apply for Medicare if eligible, and help with the case management for this patient due to all of their comorbidities and currently untreated diagnoses. Developing this support system is crucial due to their comorbidities, and it will help them access treatment and go through the process of treatment. Identifying a physical therapy practice that does either pro bono or low barrier care to help the patient address their dystonia, as well as engage the patient in physical activity to start to address their new obesity and hypertension diagnosis. We want to utilize mainequeerhealth.org, as this could potentially explore OMM at the free clinic on UNE's campus in Biddeford. The next steps to treatment include discussing with the patient whether they would like to be sober or learn more about harm reduction to address their alcohol use disorder. This includes referring the patient to a therapist or a counselor that specializes in queer identities and recovery or harm reduction work, depending on what feels most important to the patient. This can also be done utilizing mainequeerhealth.org. Additionally, we want to identify food banks near the patient to address the food insecurity that the patient experiences. Such food banks and resources include Wayside or Preble Street.
I know we don't have very much time for questions, but I feel like that last slide that we wasn't spoken about would kind of addressed Jen's question about process and about how that interprofessional collaboration happens. So would somebody mind from that team just speaking, because I know you've got an osteopathic medicine and nursing and public health. Can you talk about kind of how that collaboration went in this project?
Yeah, I can speak to that a little bit. I don't know if you want to jump in. We all worked together mostly online. We touched base or face to face over Zoom. And then we kind of jumped into the project using tools like Google Docs and a lot of email. But having that initial Zoom meeting, I think was really helpful just to get to know each other a little bit face to face. And then we also had a Zoom meeting halfway through as kind of a check-in to see how things were going. Aaliyah, I don't know if you wanted to add anything to that.
No, I think you covered most of it, but yeah, we kind of checked in with each other and just worked together. I think all of us had different experiences and a different outlook on the patient because I think we're all doing different programs, so I think that was really helpful for us.
That's great. Thank you. Chris, are we on schedule, or can we hear from Sadie? I don't know if Sadie's here.
I think I'd love to hear from Sadie. I'm going to put up the new slide. We have to wait until the audiovisual team joins us before we start the next one. So let's keep the conversation going. I'll just have the slide up.
Excellent. Sadie, are you here?
I don't know that they're here today.
Excellent. Well, not excellent, but that's totally cool. One interesting thing, Gail and Aaliyah, you talked about is how you met online, through these kind of face-to-face virtual meetings. And I think this new space of Zoom, I guess it's not that new anymore, really does afford us a lot of opportunities for still collaborating, but not being physically present together. And it sounds like this team was able to use that, especially given the fact that you were all in different programs and you were all in different, physical locations. So I think that's such a wonderful development for collaboration is technology and for having this space. Oh, I'll queue up this one because this is very near and dear to my heart, because this is an undergraduate group who were interested in looking at community schools, which is inherently an interprofessional or lots of different professionals help working together to help not just educate students, but strengthen communities. So I will let it go.
We're here to share our findings on the research we have done surrounding the interprofessional relationships within community schools. Early in the semester, we came together as a group of education, special education, occupational therapy, social work, and art psychology majors to dive deeper into what a community school was. Despite our differing career paths, we shared a common desire to help those around us and immerse ourselves in doing so. We were all brought onto the team and guided by Dr. Lane Clark, the academic director of the School of Education, as well as senior teaching professor Dr. Carol Marcotti. Phase 1 consisted of our initial research exploring the question, what is a community school? We later broke into smaller groups and were able to visit 2 out of the 4 community schools currently existing in Maine. Others were given the opportunity to interview professionals, including Ann Hanna of the Maine Department of Education. Community schools are founded on 7 principles. These principles are designed to guide schools in serving the community and their students in a whole person approach. These schools combine learning, physical and mental health, along with support for the essential daily needs in order to provide opportunities and support to everyone in the area.
There are 4 pillars that guide community schools. Let's dive into the first one. Pillar 1 focuses on expanding learning time outside of the classroom. They have before, after school, and summer programs where Tutoring and multi-tiered support systems are set in place. The goal of all these programs are to create new experiences for children that they would not otherwise have.
The second pillar is integrated student supports. These include a variety of supports aimed at encouraging learning along with promoting mental and physical health. Examples include athletics, clubs, and programs for food, clothing, and language. A variety of interprofessional staff, including pediatricians, dentists, counselors, and social workers, also work to support the students.
Pillar 3 focuses on family and community engagement through a variety of programs and services available to students in the surrounding communities. Multi-purpose rooms can be utilized for adult education and outreach events, in addition to their traditional academic uses. These resources are designed to benefit everyone within the community.
Pillar 4 focuses on collaborative leadership. The main theme is an idea called shared leadership that requires members of a team to ask for help and make decisions to build school and community programs based on student interests and needs. The two key players are the community school coordinator and the community coordinator, who work side by side to help meet identified needs by connecting everyone in one place.
As a group, we came together and explored the question of how can the University of New England students help support community schools. We were inspired and found many ways we could connect with local community schools. University of New England has many clubs and organizations that could provide education and support to students and families. In the fall next year, we hope to create a club to bridge the gap between UNE and the schools around us. We both have many resources and want to harness the opportunities we're afforded.
So proud. So I know I was deeply involved in this project, but I would love to hear somebody else in the audience who might have a question for this group that just got together. Mike Sheldon, you can start.
Yeah, good afternoon, everybody. My name's Mike. I work in the provost office. I'm curious because you all said, you know, you're all connected in terms of interest in this particular area. If you're going to now pursue, you know, leaving UNE and going on to your careers, what would influence your decision to teach in a community school versus another type of school? Is there something you learned that would say, oh my gosh, I would definitely go in this direction? Or I don't know, you know, there's some pros and cons here. So I'm just kind of curious of how this impacted you personally.
Kelly, I'll let you answer that one.
So I am a social work major, second year student here at UNE. So when I went to visit Talbot, I absolutely fell in love with the school. Actually, the community that they had, everybody was so interested in supporting the students, and that aspect of it was just so touching. So my goal for once I get my master's in social work was to go be a clinical counselor in an elementary school. So seeing the way Talbot is run and the different players that all work together was definitely like something that made me more interested in going towards a community school.
Anyone else from the group want to chime in on that one?
Yeah, I'd love to just say I actually have the awesome opportunity to do my student teaching for my elementary degree at Talbot. So yeah, when we went and visited, it was just the energy. Like everyone is supporting everyone, everyone is proud of everyone, and everyone is just there. And as a future teacher, it's a lot about looking for the right admin that's going to give you the support that you need to help your students be successful. So to have a school community that everyone outside of teachers all are supporting for the needs of the students.
Jen Janako, I know you had a question. Chris, do we have time for one more question?
Yeah, quickly.
Jen, do you still have?
Mine's more of a comment, so I'll be quick. So I just love the way that you all thought was, how can UNE support these community schools? I think that's such a critical question for all of us who work at the university. And then I would just throw it a side note for Morgan. I know you've got a portfolio site. I'm not sure the others. I didn't get a chance to look at each one, but I just wanted to say I'd be interested to see how you integrate your work through IP into what you've got in your portfolio already that would maybe meet some of those educational standards as well. So I'll be looking forward to seeing that.
I just need to speak on behalf of this group. They were so, when we started, they had no idea what a community school was. And this semester, they got to really engage with some community schools and talk to people at the Department of Ed about community schools. And now I believe that was Kelly on the last slide said next steps. We'll see you all next year because we totally have a phase 2 where we're actually going to do now that they have a really better understanding. Now we're excited to dig in. So
this last presentation is from the Interprofessional Team Immersion, which is a massive telehealth simulation we do online every semester. This team 5, were the supportive sloths, and they're going to share with you their experience caring for a pediatric patient with asthma, meeting with their that patient's parents.
Charlotte is a 6-year-old female diagnosed with allergy-induced asthma at age 4. Since her move, Charlotte has been experiencing exacerbated asthma. Recently, she had a severe exacerbation and was evaluated by multiple care teams and was placed on multiple medications at that time. Ms. Soto was concerned as Charlotte has been falling asleep frequently at school, developed mouth sores, and her face has become rounder. She's worried about how many medications Charlotte is taking, as well as the school's lack of understanding regarding Charlotte's situation. Ms. Soto, who is expecting a child in 6 weeks, has been advised bed rest. To address Charlotte's needs and her family's concerns, we are taking a multidisciplinary approach to her case.
A multidisciplinary team consisting of students from 6 different specialties convened to discuss Charlotte's care. The team participated in 2 separate telehealth appointments divided into 2 20-minute sessions conducted over Zoom. Each session consisted of a pre-brief meeting, telehealth visit with Charlotte's parents and designated team members, a handoff, and a debrief to discuss next steps. The IFD experience completed with a final debrief with Charlotte's parents to discuss successes and opportunities, as well as a debrief with all IFD teams and facilitators to discuss the experiences of the group.
Interventions that we came up with for Charlotte included using a spacer for her inhaler, diet modifications to increase her healthy foods, oral symptom treatments such as rinsing her mouth out with water after each use of the inhaler, and holistic approaches such as the maritime pint. Some of our key takeaways were the importance of patient-centered approach, recognition of the roles of other team members and their contributions, and the prioritization of communication to understand patient preference and act empathetically as a team.
While this experience proved to be very valuable, it was not without challenges. For example, a visit time of 20 minutes did not provide sufficient time for all of our valuable team members to optimally address all of the concerns brought by Charlotte's family. Additionally, varying schedules could introduce challenges setting additional time to discuss the care plan. Finally, the nature of the Zoom visit led to challenges interpreting body language and introduced technological challenges that could disrupt the flow of communication.
As for our conclusion, overall competencies of telecollaboration, motivational interviewing, and communication skills were key factors in tackling this case. Telecollaboration has a lot of nuances, and it is important to consider ethics heavily when working online. We were able to see firsthand what it is like to have a backup plan if things go wrong, how to troubleshoot the computer, and that there are certain limitations to this form of collaboration. Motivational interviewing was an important component of what we got to learn during this experience. We got to practice using open questions, affirmation, reflective listening, and summarizing it all for the patient. All in all, this was a very valuable experience that allowed us the opportunity to grow and become better future providers.
Excellent. Thank you to that group. I believe it was Hannah, Kimberly, and Sarah. Questions for Hannah, Kimberly, and Sarah about the supportive sloths. Let's see, who is here from that group? Hannah, I see you're here. You're the first name. I apologize. What did that sloth stand for? Could you remind me? I'm assuming that's an acronym.
We were required to make like a group logo as part of the experience.
Gotcha. And did you choose that logo because you felt that it would be child-centered, something that because you're working with children and parents, is it, or was there just another reason why you chose that logo?
My experience of the team names for the interprofessional team immersion is it's a mix. Some of it is designed to be patient-centered, and some of it is motivational for the team itself to remember what their primary goals are for working together as a team and working with the patient. And they're often animal themed and very cute, but we
I have no problem with it. I was just challenging myself. I'm like, oh shoot, that's an acronym. I'm sure that I couldn't find out. So you I don't know if anyone has a question for the group. I can throw one out there if no one does. One of the interesting things that you mentioned that I haven't heard other groups mentioned, because maybe this is the thing we don't want to talk about as much, but we need to, is the challenges. And you talked about the challenges being in finding enough time. I'd love for someone in the group to talk a little bit more about, you know, the hard part of interprofessional collaboration when you're dealing with patients. I don't know if someone wants to talk about that challenge from that group.
This is Kimberly. I can speak to that a little bit. I think one thing that we all kind of recognize, especially with doing this work, was that we all have really, really great things to offer, but 20 minutes is not a lot of time to bring in all of the different aspects that each of our disciplines can bring to the table. So especially with our patient, the parents were talking about all these different challenges with social issues or the medication issues and all the things that they're worried about with school. And to provide all of the aspects from my discipline, which was public health. Hannah was from dentistry. She had really, really great insight. Sarah's from medicine. She had great insight. We had nutrition and like all of these different specialties, occupational therapy, like these were all really, really great areas that we could draw from different solutions to help the parents, but just to pack all of that into such a small amount of time was really challenging.
And was that 20 minutes? Was that kind of a typical appointment time would be? I mean, how did the constraints of 20 minutes come up?
Oh, that was what we were assigned for the IPD experience, for our telehealth experience.
Got it. And I'm guessing that's probably typical for telehealth, maybe. I don't know. Yeah. Other questions for this group? Thank you for addressing that challenge. I thought that was really interesting.
I was going to ask that same question about telehealth. Just out of curiosity, we're probably at time now, but what are the benefits and the challenges of having a telehealth appointment?
I can talk a little bit about the benefits, just because we talked about the challenges, but one of the benefits was that we all were able to be there and we all were we were all present for it. And so it was easy to switch in between and all to come up with the time that we could all meet together. So I thought that was really a benefit of doing telehealth. And it was probably easier. At one point, Ms. Soto went on bed rest, but she was still able to be at the appointment. So I thought that was helpful.
Thank you. Great presentations today in such a variety of different topics, but with obviously a common theme, because that's why we're all here. So
all right, so our first presentation from IPD Team 6. This is a very interesting title here, Devoted Dolphins. All right, let's get started.
Imagine a young child's life transformed by the touch of technology and the power of collaboration, miles away from the nearest hospital. How can a team of healthcare professionals connected only by screens offer hope and healing to a family grappling with pediatric asthma in the most remote of settings? Hi, my name is Alex, and I had the amazing opportunity to work with many great individuals pursuing a variety of careers in healthcare. We were tasked with collaborating on a pediatric asthma management simulated case study. So in this case study, the Devoted Dolphins worked together as a group of 10 students to plan a collaborative telehealth appointment series where Charlotte, a 6-year-old with asthma, recently moved to a rural area with her parents. Pediatric asthma poses significant management challenges, especially in those remote and rural areas with limited access to specialized care. Here we kind of explain Charlotte's background. She is a 6-year-old diagnosed with allergen-induced asthma at the age of 4 with a persistent cough, easily winded and fatigued. Her parents, Simone and Daniel, were interviewed within these 2 series, which we'll talk about the methods in a little bit, with an active lifestyle that is limited now due to this asthma. Frequent visits to urgent care and some medications, such as her control medications of Advair, Monolust, and Claritin and Benadryl. She also has rescue medications such as her albuterol inhaler, prednisone, and other steroids. And the family's concerns are this quality of care, and this was really discussed throughout the interviews and the telehealth appointment that we had with the parents. So our team featured a variety of health profession students from the University of New England and Rosalind Franklin University, which included osteopathic medicine, public health and nutrition, occupational therapy, physical therapy, dental medicine, podiatry, and a community health outreach worker. We would like to especially thank Dr. Prast, Anthony, and Josh for helping us out with these telehealth appointments. So specifically talking about these two predetermined and simulated case studies, the specific methods and the specific setup for this telehealth appointment was a pre-debrief before each telehealth appointment where we discussed team roles and responsibilities, collaborating on setting a plan of action, goals of care, and how to utilize telehealth for SOTO's care, or for the SOTOs, and prepare a general guide for questions. Our telehealth appointments were divided up into two, where the first appointment was only with Mrs. Soto, so this is Charlotte's mom, where we wanted to build rapport, discuss the chief complaints, review any medical history, special healthcare evaluations, explore environmental components. We would then go through a debrief and a handoff where between each session we discussed the outcome of the interactions and the telehealth appointment. And then our second telehealth appointment included both parents. We wanted to update Charlotte's condition and go through any treatment modalities that we deemed appropriate. So appointment one, building rapport, we wanted to foster a trusting relationship between Mrs. Soto and the healthcare team. We wanted to understand Charlotte's primary concerns and symptoms from Mrs. Soto and Mrs. Soto herself, gather more detail about her medical history and discuss the medication she's taking. We wanted to go through these different healthcare evaluations, specifically environmental components, to explore the potential for this new rural place they moved into. Some takeaways from the first appointment, we understood that Ms. Soto cares really deeply for Charlotte and had many concerns over how asthma affected her livelihood and her school. She was getting a lot of comments from the school about, Charlotte's attitude. So we wanted to tailor a treatment plan that was unique to the family as well as follow up on any progression. We also took away that knowledge and access to different services would greatly improve Charlotte's condition. So we wanted to research and provide the family with resources for their situation, including rural access, or problem to the rural access and the asthma and oral health management. Telehealth visits are really essential for access to care in such rural areas and these places. And they present really unique challenges, which is like question types, virtual vitals and labs, and trying to get tours of the house. So we wanted to structure questions for this next interview and be courteous of time with focus on being an empathetic, patient-centered provider. So appointment two, we wanted to address previous questions that we did not get to, review and answer of those outstanding questions, updates on Charlotte's conditions as there was some observations and progresses since the last visit, and ease any parental anxiety by offering reassurance. So some takeaways of the second appointment, it really reinforced the notion that empathy is vital to connect with patients and families to be open about their situation. Having any family member, spouse, or another member person present during a telehealth visit can really alter how the healthcare providers discuss and formulate treatment recommendations. Patient goals and factors also influence how willing the patients or the clients are to achieve these goals, and access to social workers would have really helped in our situation and help improve the social burden both on the family and Charlotte through the knowledge and access to these services. So just wanted to cover through the interprofessional collaboration core principles and best practices, which we try to utilize during this time and going through each telehealth appointment. Strengths and limitations of collaborative telehealth, we really saw this improved access to specialized care that the SOTOs had. There was enhanced communication and coordination, which was amazing to see real-time and multidisciplinary team meetings between the providers. And we also saw an increase in patient and family engagement, especially in that second appointment with Mr. and Mrs. Soto. However, there were some technology barriers. The internet wasn't super reliable on some ends, especially Mrs. Soto's device. We had a really hard time with the limited exam, and we also saw that the patient had reduced connection between us. We would have loved to have that one-on-one. Bridging gaps for these rural populations and where they're at, we saw that accessibility challenges were huge. Knowledge and disparities, fragmented care, difficulty in coordinating care among all these providers were hard. We try to, have these telehealth solutions, but strengths and limitations were very evident. So we learned that effective collaboration with other health and social professions, how to utilize telehealth for our own work, how to interact, communicate effectively with patients, and how to utilize motivational interviewing and discuss changes or learned from our patient. What we would have done differently and will do differently next time is not pre-forming our questions, rather listening to the patient and engaging in those conversations in a fluid environment. Understanding the constraints with working with many professions and follow-ups after these two appointments are going to be essential. We would like to thank the CAIEP and the University of New England for the effort of all students, faculty from both UNE and Rosalind Franklin.
All right, all done. So our team members from this presentation actually here. Raise your hand. All right. All right, so feel free. We're open up for questions. Anyone have questions for the team? So I'll start a one. So in your reflection, you mentioned that in the future, what you would do differently, you would actually use a less of pre-structured questions, but actually listen to the patient. So what you actually learned from that experience, what kind of issues or things that come up through the conversation which you did not think about it?
Yeah, there was multiple topics that we had chatted about with the parents, and it felt that we wanted to go one direction, but the parents were thinking another direction of, what they wanted to talk about and not necessarily knowing what direction that might be. So just being a little bit more fluid with like, this is the direction we intentionally had, but we're going to take it into this direction, which would have been super helpful for some of the cases.
Mm-hmm. So that would actually reflect the patient-centered, right? Like
yes,
what you want to do, you want to really fit the patient's needs as well.
Yeah, and we tried our best with that. We had a line of like where we wanted to go with it, and however, there were some times when we definitely had the questions, and we just we were like, oh, do we add it in here, or we try to fit it in this, and you just kind of have to let that conversation flow naturally for patient-centered care.
Mm-hmm. This is another project from IFD. Another interesting title here, Unleashing Positive Empowerment. It's from Team 3. Let's go ahead and listen.
Hello, we did pediatric asthma simulation case and interprofessional care. This was our interprofessional team. We had Belle Bogle, social work, and Mary Obb as our instructors. I'm Essie Love with the College of Dental Medicine.
I'm Darby Melia with the College of Osteopathic Medicine.
My name is Hannah Griffin, and I'm also with Osteopathic Medicine.
And I'm Sarah Ray, and I'm with the School of Pharmacy.
We had our patient, Charlotte Soto. She was age 6, and she was diagnosed with allergen-induced asthma at age 4. These were some of her symptoms, and she was on a lot of medications, which was the family's primary concern. For us to approach this, we had to ask the question of what is the best way to come together and provide her with the best care. So we determined our values and our healthcare ethics. And by following these throughout this experiment, we were able to have improved patient outcomes.
At the beginning of the interprofessional team immersion, each individual came prepared with our ideas about what our roles may be in a case of pediatric asthma. We shared our goals of our profession, and we came together to integrate these into a patient-centered integrated care approach. And we found that we shifted dynamically as a team to address each new concern, and we reevaluated who may best address the concern at hand as time went on.
Another major takeaway we had was the importance of communication, both interprofessionally and with the family and the patient. We found interprofessionally that it was crucial to be active listeners to others and be flexible to our own priorities in order to optimize patient care. We also wanted to make sure when talking to the family that they felt heard and the patient's concerns were addressed. And we also wanted to speak respectfully and in a language the patient and their family can understand without using too much medical jargon.
And lastly, 2 overall points that were crucial to our team's success were defining roles and responsibilities before indulging in any of the work on the Charlie Soto case, and making sure to maintain effective communication to avoid any duplication of work amongst our different specialties. And just one con that we found that was a challenge for us was having too many cooks in the kitchen during some of our work within the IPI, to have too many hands on deck all at once. But focusing on the above key takeaways allowed us to stray away from this challenge we faced.
Great reflections. Anyone has questions? So I think this is the same case that presented by the previous team. And I put out a couple questions in the chat. Feel free to answer in the chat or just speak up. Go ahead, Emily.
Can I ask a question to the team?
Yeah, sure.
Sorry. You said one of the cons was having too many cooks in the kitchen. Do you feel like this was because there was so much scope overlap, or was it due to just like inter-team communication about who was doing what? Like maybe digging into some of the root causes from a teamwork analysis. What are your thoughts as a team?
I think one of the things that we discussed was when we were actually meeting with the family, some of that was shown through like we all were like, okay, we shouldn't all go in there. We shouldn't all overwhelm them with our questions. We shouldn't all like just go at them with all this stuff. And so that was kind of like, I know an example of too many cooks in the kitchen is we were like, okay, who should go represent us? Because if we all go in with our different professions, that's very overwhelming to the family. So I know that was one example, and I don't know if anybody else wants to add anything.
I'll say
I agree with everything you said, Sarah, for sure. Like it was hard to determine because the family had a lot of concerns. And every time we talked to them, they came up with something new and we were like, oh, like nutrition would be great to talk to them about that. Or like, but again, we didn't want to overwhelm them. So it was kind of hard to make sure in the limited time frame that we had that all voices were heard appropriately. And then also that we all learned different approaches to patient-centered care in the different professions. And so we were all like wanting to utilize what we had learned. It was hard to do that in the time frame we had.
Yeah, Essie really touched on this, but I think one of the biggest problems we had with too many cooks in the kitchen is just not having enough time. I know every specialty ideally would have so much more time, and these sessions were so short. We didn't have time to have everyone get to express all that they wanted to speak to the patient about.
So do you see any solutions for this for your
I can
too
take
many
this one.
cooks?
Yeah, I think what really helped us with that was really meeting beforehand and discussing our roles and responsibilities as a profession and as someone that felt comfortable with that role. So it wasn't necessarily just like because a lot of roles overlapped, like you said, Emily. So I think that a lot of it was kind of figuring out where you felt most confident and comfortable and kind of having that open discussion and meeting beforehand.
And also get back to what the first team actually mentioned, listen to the patient more. So maybe we'll focus what you want to do with the patient instead of what you want to do for the patient.
I think that sometimes the most challenging thing is when everybody on the team starts with their individual lenses, and then you put all those lenses on top of each other, you realize how many things you really could try to tackle. And then you're like, oh my gosh, but where do I start? And I think, Dr. Sao has a great point. It's like you start where the patient needs help. And it's like, what do they come to you for? And how do you focus on prioritizing things? And I think as you progress as students, you learn the skill of prioritization and then the skill of listening. And those are like the two most important things you can take away. And then as a team, you just get better. I like to talk about how like the difference between a starting team is like, you look like a bunch of like level 1 soccer players where they're just all the kids are running around chasing the soccer ball and there's just a clump of people. And then eventually as you get more skilled as a team, you actually can start to pass to each other and or anticipate where the ball's going to be when your teammate doesn't give you a look, but they're going to pass in the future. And that's a really great team. You guys are on your way. That's awesome.
All right, we're moving towards the third presentation. I think this is from one of the FIT team. All right, so this is from our FIT program team 8. The topic is navigating transportation for houseless patients, right?
Hello and welcome to Reducing Barriers for Houseless Patients, Enola. Enola is a social and outgoing individual who enjoys spending time with her friends, who always lend a hand or a couch to surf when they can. She was recently diagnosed with stage 2 chronic lymphocytic leukemia. She's currently being treated in Portland, Maine. She was previously labeled as non-compliant due to her health and access barriers, which include houselessness, communication devices, transportation, and uninsured from health insurance. She is a Cherokee Native American woman who was displaced when moved away from her tribal community at a young age. Here we have a framework of Enola's life. As I mentioned, she has poorly managed stage 2 chronic lymphocytic leukemia. On the individual level, she is unemployed. She's eligible for Medicaid and Maine Care, but she has difficulty with the paperwork. She also has poor nutrition and she's underweight. In her family and friends, she has no living family, and she relies upon her friends for couch surfing and social support. For her broader community, she lives in Poland, which is a small rural town with poor walkability about 30 miles from Portland. And finally, in her environment, she has no access to a car, no cell phone plan, so she relies on Wi-Fi for communication, and she has no reliable transportation to treatment.
As a team, we've come up with various interventions that may help Enola. To begin, we'd like to get her a case manager that will assist in the enrollment in Maine Care, allowing her to access many of our intended interventions. With the help of her case manager, we'd like to move her treatment from Portland to Lewiston, Maine, with the Central Maine Cancer Institute, which is only 11 miles from Poland than the 31 miles before. Enrollment with Lifeline will give Enola access to a phone plan, which she can use to schedule transportation to and from her appointments. In regards to nutrition, the case manager can assist in the enrollment of SNAP and use Uber Health for delivery of food. Through the Cancer Institute, they can assign her a nutritionist and give her access to a cafeteria and a kitchen. Similarly, we can help her apply for short-term housing with the Arbor House associated with the Cancer Institute. However, we'd like to find her long-term housing in Poland through the use of resources like Avesta Housing. Lastly, we plan to not only foster health, but social and mental support for Enola. Through places like the Dempsey Center, she will have chances to build community with others. We also want to help Enola foster a stronger connection with the Indigenous community through Tribal Health Liaison. Similarly, we'd like to help her gain her sense of self and cultural identity by acquiring a wig through the American Cancer Society. With this multifaceted approach, we hope to address Enola's needs.
All right. So we're gradually moving from individual patients and then to look outside the patient and what we can do to help with the patient. Feel free with any questions, and also feel free to turn on your camera. We would love to see your face. Any questions? I can start with one. This is a kind of combined with the first case we heard. This is about the internet issue. So we're a rural state, and then not everywhere has the same quality of internet connections, and it is important for every patient. Even you give the patient a cell phone, and a lot of time it has to require Wi-Fi. What would you guys do to help us with this problem?
Sorry, to make sure that I understand the question. Are you asking, like, how would we kind of circumvent the issue of rural places not having reliable Wi-Fi?
That could be one of the solutions, and the other thing as well. Anything you can think of.
For how to do that? I'm not sure what the question is.
Well, maybe give us some suggestions. You could circumvent that.
Oh, okay. Gotcha. Hi, Dr. Sao. I can jump in here. I'm not too familiar on internet in the rural areas, but I imagine by researching each individual county, we could figure out which area or which plan has the best access to Wi-Fi, and then hopefully via something with Maine Care or with social work, trying to get those prices reduced for whichever company has the best Wi-Fi in that state. In terms of getting additional Wi-Fi, I think that would take a lot of advocacy in terms of outside health, outside of social work, but that would be our first step, I believe.
That's perfect. That's exactly where I want to going for. So besides really just, taking care of the patient in front of you, seeing the bigger pictures is also important. You could treat 100 patients who also, who has all variety of problems, but all have the internet issues and you cannot solve. So advocacy is your responsibility as well. So looking outside, you might not think this is a part of the healthcare, but it is with the telehealth usage, and there was a lot of telemedicine, and you prescribe medicine, you interview patients, and you all need internet. So everything is related, and if the population is not healthy, individual cannot be healthy. So this is exactly where we're at. I want to go into advocacy. All right, so the last one is also part of our FIT program. This is really near to my heart. It's a topic about a chronic pain, a case of a chronic low back pain, interprofessional approach. All right, let's get started.
Hi, my name is Hunter Scott, and I will be representing Group 5, and we will take you through a case of chronic low back pain with an interprofessional approach. We'll first discuss our patient, the narrative, our model, and interventions, and the healthcare team involved. First, Mr. Plant is a 76-year-old male shipbuilder from Bath, Maine, with a 30-year history of chronic low back pain following an incident at work that led to spinal fusion surgery. His pain is currently a 6 out of 10, which was previously managed with opioids, but he has since transitioned to over-the-counter pain medication. He's presenting to his primary clinic with a change in his pain pattern, plus anxiety, depression, and he's wondering how he can improve his quality of life. We'll examine this patient's individual, interpersonal, community, environmental, and policy factors that affect his health. So first, from an individual level, his occupation, past medical history, and plus comorbid conditions and lifestyle factors all impact his health. From an interpersonal perspective, his wife has become desensitized to his condition over the years. He's also estranged from his children and siblings, and he has lost touch with some of his friends through work, and has had a difficult time maintaining connections. From a community level, he lives at a greater distance from his care providers. The pain has also limited the interactions he can have with support groups and religious services he used to attend. His town is a rural coastal community in Maine where he's able to travel by car, but the pain can limit this. And he does receive some workers' compensation, but he's wondering if he is entitled to additional coverage. This is a summary of what we just covered. And for interventions, we will first consider physical therapy to address some of the patient's pain and sedentary lifestyle, plus comorbid conditions. This can all help with that. Riverside Physical Therapy is available in Bath, Maine, but it should be noted that this may require prior authorization by his insurance. Additionally, he can acquire Maine Care coverage as a disabled adult, which could provide some assistance with additional costs and also potentially provide a case manager that could help manage his complex condition. And lastly, behavioral health services could be sought out for both he and his wife due to a positive PHQ-9. And all of these healthcare providers can be found locally within the town of Bath to provide support. Thank you.
All right, we are open up for questions. Anyone want to ask your questions? All right, so I want to ask of the team, team member can raise your hand so we all know who you are. What does your patient actually want at this point?
I can answer this one for the team. I think that we sort of envisioned that he came into his appointment just as sort of routine follow-up for his pain. But during the visit and a little bit beforehand, we found out that he had things that were happening outside of his life, namely his anxiety and depression, that were sort of exacerbating his pain and making it hard for him to do things that would help his pain, like his fear of movement because of his pain was really impacting his ability to heal and remain positive. So I think that identifying the anxiety and depression was really key towards making a new plan that wasn't just a continuation from the old of managing your pain and doing the same thing at the visit. I think there's a question from Mr. Sheldon.
Yeah, I'm Mike. I work in the provost office. You may have just answered it because very appreciative of acknowledging all the different team members who might contribute to, this particular client's, resolution of their issue, or at least, helping to mitigate what they've been dealing with. But if you had to sequence them, prioritize, and it sounds like based on your answer, that maybe addressing the anxiety piece that you identified would be something that, okay, we can't do everything at once, but this would be something. In fact, we definitely want to do that before, let's say referring to physical therapy, where they're more likely to, want to initiate, movement therapy, that type of stuff. So I'm just kind of curious if, in your minds, okay, priority wise, we'd want to start here and then kind of move through in terms of the plan that you were working on.
Yeah, definitely. I think during the visit, identifying what the patient identifies as his first priority, or what matters most to him in his treatment plan, is the best part of moving forward in his care. Hunter's laughing because we both do the GEM project, and that's the biggest part of that, is identifying what matters most for your older adult patients. So I think if he isn't ready to start PT, then doing a PT recommendation at that visit isn't really going to help him. But maybe through his support groups, he can identify like, okay, I feel ready to start PT now. And that's what he can work on down the road or work towards now. Hopefully that answers.
Yeah, thank you.
Yep. Yes.
All right. So I kind of want to get back to the core of the program, the public health component of this. And then chronic pain is a really significant public health issue. So through your sort of workings, the project, what do you think is the number one priority you should advocate for?
I think, like we said, like our patient lives in like a more rural area of Maine, and I think one big thing that is a barrier to him is like access to resources nearby him. So maybe just like trying to work with him and work with other companies like transportation or like other ways that he could get telehealth appointments or stuff like that, so he could have like access to all these resources, like maybe closer to home.
Think about it, advocacy also, not just, one or two other partners. You could work with the state, could work with the universities, it could work with the companies, healthcare systems. So that's all become your partner to work on this. So another related question. So we have started this pain registry, and so far the participants are actually have a good housing, good stable job. On that part they're not lacking or has a disadvantage, but whoops. But their issue is a lot of was frustration with the providers. They don't understand my pain. They don't have anything else to offer to me. Just quickly, I know we're ending. Anybody have a response to that?
I think you actually kind of touched on it earlier when you were talking about advocacy. One of the things that providers I think can do and are doing probably a really good job at is getting creative with solutions for patients. It starts with listening to what their primary concerns are, but it also is sort of like thinking outside of the box of medications or like stretching or going to PT. It's sort of listening to what your patient's barriers are and their concerns and thinking with them, not just for them, about what you can do to help them like accomplish their goal of lessening their pain or getting rid of. It's not always about, eliminating the problem entirely. It's about making their life, their quality of life feel like it's higher.
Exactly. All right, perfect. And thank you all for coming and the great work, and hopefully to see you guys in this become the leader in interprofessional practice in the future.